and we agreed that I would inject 1/2 of the face, and I will inject the temples. I will treat the quality of the skin, so with diluted Radiesse, 1-to-1 dilution Radiesse, and I will treat her nose augmentation, and what was the last thing? I was going to treat something more. What was it? Maybe chin, right? Chin, yeah. Commissures, yeah. All right. Oh yeah, and we said we were going to do a little bit of revive in her crow's feet area, periorbital. All right, let's start with some anesthesia, some marker. Can I have a marker? Thank you. Let's start with the temporal area. Right, the temporal area is defined as the area between the temporal crest, the lateral orbital rim, and the zygomatic arch over here. All right, so this is the area that we're talking about. What I usually do is take that temporal crest entry point and go with my cannula laterally. You can also take the zygomatic arch entry point over here and go up. Or you can do both. So maybe I can show you both today. Anesthesia, please. Thank you. And a dry swab. Where's the dry swab? Here. So before I anesthetize the entry point, I just want to make sure that there's no pulsation. So there's no pulsation. I can just put the needle in and inject a little bit of lidocaine. Over here, I will inject a little bit of lidocaine as well. Now, I will take Belotero volume for the temple, and I will use a 23 gauge 5 centimeter cannula. And these are, let's see, soft fill cannulas. And I'll make a pre-hole over here and a pre-hole over here. So I will start with the frontal entry point. So here's my entry point. I put the cannula to the subcutaneous layer, and I will show you what it looks like if I keep it subcutaneous. It looks like this. But if I first take it through the gallia, I'm on periosteum, and then turn it around, it looks much different. Do you see the difference when I try to pull it up? So now I know I'm in between the two fascias. I will start to inject a little bit of product. And I'm giving her retrograde linear threads. And now I've injected approximately 0.5 cc's. Let's see, exactly 0.5 cc's. She's Orit's mother, and I talked to her husband on the phone, and he warned me, I want to recognize my wife when she gets home. I'm like, okay, don't worry, I will not over-inject her. All right, so there's one side. Let's have a look. You see that a little bit of visible deposition. So with Belotero volume, it's important that you even that out. So that means a little bit of a push, a little bit of evening out, you know, to make it smooth, because it may stay that way if you don't do that. Now, I also will start from the lateral cheek entry point. So this is subcutaneous, and I want to go one level down. So I go down, click. So now I'm below. If I pull up, it looks different, as you can see. And again, I will inject a little bit of Belotero volume over here, just to show you two different approaches of the temporal area. In total, I've injected 0.6 now. So the last was 0.1 only. And do you have the radius prepared? Fantastic. Thank you very much. This is a 1-to-1 dilution. And can I have a cannula on there? Maybe a blue one. Blue one is, yeah. Blue one is good. Thank you very much. So this is skin laxity. Over here you can see laxity of the skin. And what I'll do is, from here, I will mark this area like this. So this whole area, I want to stimulate. Because, you know, if you look at this, you know, all these fine wrinkles over here, if I get too close to the orbicularis muscle, I may cause some problems like malar edema. So normally I stay away from this very thin skin. This is where I'll be injecting Belotero Revive. So this is the Revive area, and this is the Radius 1-to-1 dilution area. Same cannula, same entry point, and now I will stretch the skin, advance the cannula underneath the skin, and I put the bevel up. There's a little bit of air in this syringe, guys, girls. You see when I do this, it's a little bit compressible. Normally, I really take care not to include any air into my syringe because it makes the product spongy. So when you come down here, this is where we have the zygomatic retaining ligament inserting into the skin. So there's definitely some resistance. So I kind of like rotate and push the cannula up and down until it finds its way past those resistances. I move down. Somebody had a question? All right. Needle? Or actually, you know what? I'm mark first.
Mark now.
So I've injected 0.5. 0.5 here. All right? Now, here I will have another entry point. And I inject here. Here I will have another entry point, and I will inject here. And here I will have another entry point. I will inject here. And I will stay away from the jowl. I gave her some anesthesia previously, so might as well do it again. 1, 2, 3. 1, 2, 3. And 1, 2, 3. So I will start over here. 1, 2, and 3. Dry gauze, please. Thank you. Okay. Second entry point. So stretch the skin, advance the cannula at the dermal-subdermal junction. And you know, this is where there is the facial artery, also in this area, so we have to be gentle here. And okay, you know what? I'm gonna stop using this syringe. Do you mind if I show them how to mix? Can you give me one syringe of Radiesse? Because I don't like to have air inside the system. Can you give me a new syringe of Radiesse? New? Open from the box?
Yes, it's one dilution.
No, a new non-diluted Radiesse. And 2 syringes, 1 syringe with 0.5 cc's of lidocaine and 1 syringe with 1 cc of saline. And a lure lock connector. And I will show you how to mix, because as you could see, this was a little bit compressible. And you know, these girls don't have so much experience with mixing diluted Radiesse, and there's always these little air bubbles that get trapped inside, you know. So, and this is a little, you know, little tip that I want to give you guys, because it's a little bit annoying if the gel contains a lot of little air bubbles, and you start pushing, and first you compress the gel, and then it starts flowing. So, I will show you how to mix it. Okay. This is 1 syringe of Radiesse. It has the clear cap, which means is the classic Radiesse. The classic Radiesse. The Radiesse which has no lidocaine inside. Then, what is this? Saline. What? Saline, 1 cc. All right. Can you give me another syringe of this? With lidocaine, 0.3? Okay, because it has a little bit less. Okay, over here, let's see, how can I do this? Over here you can see this is 1.2 cc's, or what is it? Yeah, 1.2 cc's. Where is my marking? Oh, over here. Right, 1.2. So I attach the lure lock connector. Now this is usually where it goes wrong, because in this whole system there is some air. So I have to take out the air by pressing. You see now there's no more air in the system. Oh. All right. So the second syringe also should not contain any air. So I also take out the air of the second syringe, right? All right. Now, when I attach the Radiesse, you will see that mixing it just like this is not working, because this way it works, but that way I get to the maximum, right? So it's not really mixing well over here. If you would try this with Radiesse Plus, you would be very unhappy, because there is no more stop in this part of the plunger, and you can express the entire plunger with all your product that will fly out over the floor or over your patient. So I rather use 2 syringes for mixing, right? So I have now the full distance of the diluted Radiesse, and as you can see it has 3 cc's, which means that now it's a 1-to-1 dilution and there are no air bubbles inside the system. Then I remove one of them and reattach the Radiesse syringe, and now I can use that Radiesse syringe for the rest of my treatment. Okay. So I had 0.5 injected, and I'm continuing the treatment from here. Retrograde linear threads. And now it's not compressible, which is much more convenient. She already has some collagen production because of her therapy, so it's a bit more difficult to get past some of the collagen resistances. Could I have a gray needle or a blue? All right, let's try. Thank you. So from here, I'm already halfway with my syringe. And then the last entry point, I will put some more product into it. And so from here, I will treat the lower part of the face. There we go. Superficial, I go to the preauricular area. And here I can really inject a nice amount, especially at the mandibular angle and the mandibular borders. And again, I make sure I'm not injecting inside the jowl, just lateral to the jowl. Okay. How are you feeling? You okay? Mm-hmm. Yeah? All right. So can we switch to Belotero Revive, please? Okay. Let's do both. Let's start with cannula. Actually, let's just do the needle. Let's do the needle that is included in the box. All right. So this is the newest Belotero product, and it does not contain any lidocaine. So sometimes it's nice to cool the patient, also for a little bit of vasoconstriction, and it's nice maybe sometimes to give a little bit of anesthetic cream. Now, I want to inject in this area especially, because this area, there's a lot of wrinkles, but it doesn't look good if you put any toxin there. If you put toxin there, the smile becomes very strange. So I will just inject some superficial, just subcutaneous deposits of Belotero Revive. And with Belotero Revive, you just put micro drops of about, I don't know, 0.01 or something, 0.02 maybe. Just small amounts, and as you can see, sometimes you get a little bruise, which is okay, it will go away, they're small. And just make sure that you try to avoid these little periorbital vessels that you see a lot in this area. And then after this, you will have a little bit of a bumpy result. 0.4. So I go a little bit higher. And the nice thing about injecting it, especially in this area, is that you will have more of a refracted light reflection. There will be maybe just, because of the tissue containing some water, it will play with light reflection, and it will give more of a glow to the skin because of the hyaluronic acid attracting some water. So I even it out to reduce the little lumps and little bumps, and I put a little pressure because there's always a chance that you've hit something. While we go to the next indication with Belotero Intense. Yes, because we're going to do nose augmentation. A cannula, please. A 22 gauge cannula, please. So remember, guys, for the nose, this is the second area of most association with vision loss after fillers, right? The first being glabella, second is nose augmentation. So with nose augmentation, we have to know what we're doing. So again, we have to know the anatomy. As you can see, her nose is actually quite okay. There are usually 3 possible angles that you can correct. 1 is the nasofrontal angle, 2 is a supratip, and 3 is the nasolabial angle. Now in this case, especially the nasofrontal angle is important because we want to hide a little bit of the dorsal hump, and maybe we want to play a little bit with light reflection, making the nose look a bit thinner over here. So what I'll do is I start with a little bit of anesthesia and little swap. Please lean back. And I'll show you the easy technique. Right? The easy technique, you start at the dorsal hump. 1, 2, 3. Little bit of anesthesia. And you start for the second one on the nasal tip. 1, 2, 3. And that's a bit painful. I'm so sorry. Now, when I do this at home, I often also use a 25 gauge cannula, but just to emphasize the extra safety precaution, I use a 22 because it's more difficult to get into a vessel than the 25. I suspect her of having had a glass of wine before the show. What do you think? She did. Oh. No, you didn't? Oh, okay, good. Did you take any anticoagulants today? No. No? Okay, maybe you just have a lot of blood. Royal blood.
Do the other side afterwards, right?
Dorsal nasal arteries are lateral to the midline.
יותר גבוה.
מה זה עוזר שאני...
Can you let it go? Yeah, stop bleeding. All right, good. So the dorsal nasal arteries are lateral to the... Where's the marker now?
The marker.
Are lateral to the midline. So this is a midline. The dorsal nasal arteries are here, and they're connecting with the supratrochlear arteries, right? So we have to avoid hitting those, but they're usually lateral to the midline. Of course, anatomic variation, everything's possible. So they are also located subcutaneously. So if we want to be safe, we have to go sub-smas. So we lift up, click through, and I feel periosteum. And now she's thinking, oh, Riet, I love you, but I hate you for talking me into this.
Exactly.
And I inject 0.05. You see that I'm also compressing her supratrochlears? 0.025. Again, I re-advance the cannula. 0.025, right? Re-advance. 0.025. And I take my time. Even though she might feel a little bit discomfort, I take my time because I know it's better to have a little bit of discomfort now to actually risk the most serious complication in aesthetic medicine. So every time I press the plunger, I'm looking at the markings. And every time I do not exceed 0.025. I can also do less, you know, that's fine, as long as you don't do more. 0.025. I like that beat in the background. What is that? Other party next door? Guys, what are we doing? We're just here working.
The birthday party.
A birthday? So, as you can see, I'm taking a long time to inject 0.2 cc's of product. Now, looking from the side, you see that it's starting to improve already, right? Now, the ideal location of the nasofrontal angle is at the supraciliary line. So don't continue too far up, because then you will start to make a Greek profile, which is not very aesthetic, right? So you have to know when to stop. You have to feel when to stop. The supraciliary line is the lash line. Can you open your eyes, look in the camera? Look in the camera. So the lashes, in between the eyelashes, you end up right here. So this is the ideal position of the lash line. Okay, you can lean back again. And now, as the last one, I will go into the subcutaneous plane. This is actually the area of the leveled anatomical layer of the dorsal nasal artery. So that means that I cannot have any resistance. So I'm using, and I like to call it the tea time technique. I have one pinky up, and as you can see, you know, I don't use any force. I just very gently wiggle, wiggle, wiggle until the cannula is up here. And this is for light reflection. Again, I press here and a retrograde linear thread of 0.025. Again, it's the same amount, 0.025. I re-advance subcutaneously and 0.025. And I think 0.05 is enough to create a little bit more sharpness in light reflection. So, Orit, you know you are my timekeeper, right? Yeah, so tell me. 10:15, do you want to change?
What else do we want to do that we didn't show?
It's up to you. You're the big boss, Orit.
So we did all this.
We did all this, and we were going to do chin augmentation.
Let's do the chin.
Should we do chin? All right, let's do chin. All right, so for chin augmentation, okay. You can have different approaches for it. So we're going to zoom down to the chin. So this is a midline. This is the mental crease, marionette line, pregel sulcus. So what you can do is anesthesia. Two approaches, one from the pregel sulcus for subcutaneous and one from the midline for submuscular. All right. That's with adrenaline?
Yes, with adrenaline.
Can I have the pre-hole needle? The gray one. Thank you. Okay. All right, one here. Now, why do I use this medial one for submuscular and this one for subcutaneous? The reason is that if you think about the facial artery running up here, the inferior labial artery running this way is located submuscular in most cases. And it is running parallel to the cannula if I come from here. So if I stay subcutaneous, I'm in the other anatomical layer, so I don't have much risk of actually entering into the vessel. So I am able to inject subcutaneously relatively safely. Again, of course, it's small retrograde linear threads, Belotero intense. I can go up to the oral commissure. Giving a little bit of anesthesia, and also, you know, you see that the cannula, wait, I have to go a little bit more superficial so you can see better. If I want to go more superficial, I just push the syringe down in order to get the cannula to stick up against the skin. And I can even go just a little bit into the upper vermilion border. And I inject retrograde linear thread. And also, of course, I can work on the contour. You can also do this with Radiesse, obviously. But with Belotero Intense, it also works very, very nicely. Subcutaneous. Can I have another Intense, please? Thank you. Now, from the medial entry point, I can also go submuscular. If I can find the entry. All right. So right now I'm in between the two bellies of the mentalis muscle. And I can check if I'm not too far. As you can see, the cannula tip is not in the oral cavity, right? It's not even touching the mucosa, so I'm still good. And I can inject, I'm injecting right now, little amounts, 0.1, 0.1, another 0.1, 0.2. All right. And then you get an anterior projection of the menton. So from here, you could also correct bone resorption. You see that she has a little bit of a depression here. And so from here you can go underneath the depressor labii inferioris muscle, right here. But then again, you have to check if the cannula tip is not entering into the mucosa. Check the tip location and inject. And inject a little bit more below the depressor anguli oris, the DAO. All right. Okay. So that concludes chin augmentation. Now, of course, we have to include also one little bit of needle. Can I have a 20 gauge needle? 27, a gray needle?
The gray?
The gray needle? Yeah, great, thank you. A little dots on the eye is always nice to give. Small amounts. Belotero Intense. Pushing up that oral commissure. That's what we promise her. All right, can you zoom out a little bit? Can you sit up a little bit? Can you look in the camera? All right, so what we've done, temple, volumizing the temple. You see depression over here, correction, skin quality improvement with Radiesse on the cheeks. These little bumps are Belotero Revive. They're going to improve the skin. The bumps are going to reduce. We've augmented the chin, gave her more of projection over here, reduction of the mental crease, pushed the oral commissure up. And we have, first of all, created the nasofrontal angle. And second of all, we have made a sharper light reflection of the nose. In total, what did we use? 1 syringe of Radiesse, 2 syringes of Belotero Intense, half of a Revive, and half of a volume. Okay. And next time I'm here, we'll do the other side. She knows I'm joking. So I will finish the treatment much quicker after the second patient. All right? Okay. All right. Thank you. So is everybody still awake?
Yes, we have a second patient.
Come higher. Come higher. Yeah, like that. Okay, perfect. She's full of anesthetic cream. Yeah, lay down, lay down. All right. Okay, let's use new needles for this patient. I'm just joking, guys. I love Orit. I love Orit, but this woman makes me work. You know what time I started this morning? Seriously, we did a whole day in Alphamedix office, right? The whole day lecture. I was like talking the whole morning, afternoon, hands-on training, like the whole day. Interview with a journalist. Then all my friends needed injections, you know? And then Orit's friends needed injections. So, and then, okay, so we had a little bit of time so I could go to the hotel, shower, change, and come to you guys. So that is my day. Okay, and I'm not gonna even talk about yesterday and the day before yesterday because it was the same. So this girl makes me work. So what am I here for? Work. But you know what? The nice thing, hanging out with Orit, it doesn't feel like work. It's so much fun, seriously. We are laughing the whole day. This girl's amazing. It's just fun, you know, we just enjoy it so much. Okay, let's dive directly into it. Can I have some gloves and some anesthesia, and I will start marking. Frontal concavity, guys. Frontal concavity. Gloves. Alcohol sounds good. Very soon. Thank you. Right. For the forehead, if you inject in the forehead, in the subgaleal space, you will understand from your patients that it's quite intimidating, because if you scrape with your cannula over the bone, the patient hears this loud noise over the bone. And you know what? People are not used to other people making noise inside their face, right? There's something very strange about that. And the periosteum is also a little bit sensitive because there is a supraorbital nerve running there. You know, so you're very close to the sensory nerve. Together with that sound, it can make the patient really tense up. And you know, I had the experience of a young man, and I was injecting him in front of a big audience, and I did not prepare him for this sound, and he's just like started holding his breath. And I didn't realize it until it was too late, and he went vasovagal, and you know, then I had to stop it. So right now, I tell the patient before she may hear some sound, right? And I numb her. So not just the entry point, which is the same entry point as the temporal area, but also I will anesthetize the supraorbital nerve, which is over here. The supratrochlear nerve, which is over here. And the zygomaticotemporal nerve, which is somewhere down here, behind the lateral orbital rim. Okay. All right. Now that should remove or reduce the pain. And the product of choice in the frontal concavity for me is Belotero Intense. Of course, you can give amazing results with Belotero Balance as well. It's very easy to even out the product with balance. But yeah, I will use a cannula. I will use a 22 gauge cannula, please. But with Belotero Intense, you need much less product to get the same result. So that's why I use Belotero Intense. That's why I use Intense, because you need less product to achieve the same result that you can achieve with Balance. And the needle. So the same reason, a 22 gauge cannula, safety precaution, because it enters into blood vessels much less easy. Thank you. And remember, from the supraorbital foramen, there are the branches of the supraorbital artery. From the supratrochlear foramen, there's a supratrochlear arteries going up. A drop of blood looks big on a screen, huh?
Yeah.
Okay. Okay. Let me find this entry point. Here we go. So, I'm subcutaneous, it's too superficial. See, if I pull up, looks like this. So I want to go below the muscle, so I lift up the gallia, I lift up the muscle, and I feel the resistance of the gallia. I rotate and I press through. I feel click. Now the cannula is on periosteum, and I feel that. Do you hear that noise? Does he speak English? No. I was explaining about the noise and you didn't translate? Thank you, Orit. See, never a dull moment with this girl. Yeah, she hears it, she hears it. Okay, thank you. Thank you for translating that. I have to learn Hebrew. You know what I learned when I was having dinner in Nazareth? I learned that the Israelis, they have a name that means something. You have a name, it has a meaning, right? It means something, and it's usually something beautiful. So I thought, what does my name mean? And I looked up the Jani meaning, and it turned out it's a Hebrew meaning. The Hebrew baby name. And it means gift of God. Isn't that funny? So I feel the cannula scraping over periosteum. And the beat in the background is getting louder. So I feel very close to you guys now. Already. So I'm injecting lots of very small deposits. You see a little bump over here. I will even it out. So as you can see, it's becoming nice and smooth already right here. You see that? Now, medial entry point. Again, a little bit of anesthesia right here. Thank you. And actually, maybe it's easier if I stand. Can I have the needle? The entry needle? Thank you. Maybe can I stand behind here? Not really. Okay, doesn't matter. Doesn't matter. go. Can I have the syringe? Thank you. Okay. All right, can you see it like this? Yeah, you can. Okay, great. Okay, let me move this way. All right. So, also from the medial entry point, I lift the muscle in front of the cannula, and the cannula goes through the galea, underneath it, to the periosteum. The bevel goes down, and I start injecting retrogrades, small retrogrades. Small retrogrades, you know, I don't want to inject a lot of product per retrograde. And again, I take my time, right? Now, when I get to the midline, I start to inject even less, and I start to look at the markings on my syringe. And I also start to put a little bit of pressure on the supratrochlear arteries. Now, normally, I would walk to the other side, but actually you walk to the other side, Ovid.
What? You want me to walk?
Actually, you know what? I'll come and inject from that side, because I'm injecting with my left hand now. It's okay. All right. All right, so it's a good practice to keep on pressing those supratrochlear arteries. And whenever I feel a resistance, right now I feel a resistance, and that means, you know, I hit the neurovascular bundle that is attached to the bone there. So I don't force it, I just, you know, start to inject small amounts, 0.025, and I am not in a hurry. And it may be a little bit sensitive. All right. Can I have a swab, please? A dry one, please. Thank you. Where's my nurse? Where's the nurse?
She went
To have a wine? To have a glass of wine? Aye, aye.
no, not a wine. Coffee.
Okay. You guys get that I've been working the whole day, huh? Okay. Oh, good. Now let's have a look. Can you sit up? Can you ask her to sit up? Can you look straight in the camera? Now, as you can see, there is a difference between the light reflection on this side and the light reflection on this side. Now, there is concavity here, you see, and there is convexity on that side. You see the difference, right? Now, also you see that this brow seems a bit higher, but usually actually the treated side gets a lower brow because of the anesthesia in the frontalis muscle. Can you raise your brows? See, this is blocked because of the anesthesia, and this is still active. So normally this brow falls down, but later it comes back up after the anesthesia wears off. From this angle, this brow looks really high, but I know that from that angle, this brow looks higher. Is that correct? Yeah, from that angle, this brow looks higher. From the middle, what's from the middle? Which brow is higher? This one is higher? Okay, so you see that pushing up the muscle is pulling up the brow. You see how it works? All right, so I start at the vermilion border. 1, 2, 3. And I introduce the needle into it, into the vermilion border. I advance it. I start to inject retrograde linear thread. 1. This is just standard lip augmentation with needle. 2. And of course there's all kinds of variations that you could use. 3. 4. And 5. Sorry about that. Then of course you can do a little bit of filtrum. And after she breathes in and out, yeah, okay, this is without anesthesia, just to show you that it's definitely possible. And now a little bit of blanching in the radial lip lines. 1. You see that I place my needle very superficially. I start to inject. And there's a little bit of white halo. This is Belotero lips contour. It's actually very similar to Belotero balance. It's packaged in a 0.6 milliliter syringe, and it behaves exactly the same as balance. So I know how to press, how much force I can apply to the plunger in order not to overcorrect this, but to give a nice correction. What's that? Thank you, Orit. So fortunately, when I get to Israel, you make me work. I think it's because when she came to a conference in Cannes, and I needed an assistant on stage, I said, Orit, come from the audience and assist me. And so she was assisting not only me, but all the other doctors after me as well. So I made her work too. Ha ha ha.
Little revenge is in life.
Revenge. A sweet, sweet revenge. Okay. Let's have a look. Okay, that looks pretty good. Others, let's see. Another way of doing this is going from below into the lip, low into the lip, and this is also giving hydration. So if you only inject Belotero contour, you can use it in this way for not only vermilion border extension, like contouring the lip, but also for hydrating the lip, because this also gets into the cutaneous lip of the red lip. So this is Belotero lips shape, the dry red lip. Different ways, you know, there's different ways to roam. You know, a lot of people go from here, end up with the needle at the dry, wet junction. But, you know, because it's very easy to pass through the muscle, I think, and because the artery is usually running just here below the muscle in the submucosa, I think it's safer to just inject right here. In the dry part of the red lip is the lowest chance of getting into the superior labial artery. And you know, with her, I'm not gonna inject a lot of product. I'm just gonna inject a little bit because I don't want to overinflate her lips. To tell you the truth, it was Orit's idea to inject her lips. I did not really. I did not really plan to do this. Okay, but as an alternative to that standard technique, you can also use this technique, where you advance your needle subcutaneously to the wet-dry border and give a little bolus. And also over here, give a little bolus. And also over here, give a little bolus. So for the lower lip, we focus on the medial part. The upper lip, we also go down to the oral commissure, and of course that is also where we want to create a little bit of extra lift to have that nice secret smell. Orit. Okay. All right. Can I have some Belotero lips contour with a do we have?
Wet one? Or a dry one? Wet or dry? What do you want?
It doesn't matter. All right. So from here, I introduce the cannula into the vermilion border. All the way to the top, and sometimes even past. And as you can see from here, it's also possible to inject in the same area, but without a needle, with a cannula. You see, it's very easy to do with a cannula too.
זה פחות הנוער, נכון? מאוד נורא, יותר מאשר.
She doesn't like me anymore, does she? And can you put that needle back on the contour? Can you open? Orit, can you swipe? Wipe, yeah. Can you put the Belotero lips contour with the needle, please? And now, as you can see, I'm also introducing the cannula into the vermilion in the dry portion of the red lip, and I'm also injecting some product in the vermilion on this side.
Contour, yes?
Sorry?
More contours.
Yeah, more contour. Or you can find it. And of course the blanching you cannot do with the cannula, so you have to do that with the needle. Okay, so you get the idea, right? Small drops, starting to blanch. As you can see, it's a little bit white now, but it will become less white after a while. Of course, it's also possible that with Belotero you do the standard line filling technique like this, retrograde linear threads, which is not really the blanching technique, but it works too, as it's like a standard HA technique. And you know, especially for wrinkles a bit deeper, it's good to do it like this. All right, but actually I was going to do only half of the face, and I'm starting on the other half as well. So, is there anything else? Is there anything else? Because what time is it now?
We have 10 more minutes, about 10 minutes. So
10 minutes?
Want to just do maybe like...
Cheek augmentation. All right. There is the zygomatic arch over here. Lateral orbital rim, zygomatic arch, and it's going down like this, all the way forward. Then infraorbital rim over here, right? That's bone, right? This is all bone. Now, the ligaments, in her case, you can very clearly see the insertion of the orbicularis retaining ligament right here. It's a bit more difficult to see the insertion of the zygomatico-cutaneous ligament, but it is over here. And the zygomatic retaining ligament insertion is about here. Sometimes they are continuous with each other. But this is the skin insertion. The bony origin is from the orbital rim, then just lateral to the infraorbital foramen, it takes a sharp turn and goes horizontal over the bone. And sometimes it is continuous with the zygomatic retaining ligament, but usually is a little bit of distance between them. So if the ligaments are oriented like this, preventing downward pull, what we can do is we can reorient them by pulling up and then putting a product underneath it so it gets erected, right? So we have a change in position, change in orientation of those retaining ligaments. So what I'll do is I'll make her hair completely wet because I like wet hair. And I start from the top of the zygomatic arch. And I will have a 23 gauge cannula. This is actually nicer to use a 22 gauge needle to make a pre-hole for the 23 gauge cannula. And so what I will start is, first of all, I will go down just inferior to the infraorbital rim. Lateral orbital rim, this is the place that needs a little bit more light reflection. So a little bolus and a retrograde. I advance again over periosteum, and I feel resistance. So I feel that resistance, so I lift up the ligament and go click through. I give a little bolus and a retrograde. Again, I continue over periosteum, a little resistance, bolus, retrograde. I don't feel any resistance here, so maybe there's no more ligament. I go back. Resistance, retrograde. I'm also looking at the shape because it's not just the lift, it's also augmentation. So I move a little bit further laterally. And now click. And I pull up, bolus, retrograde. Okay, and I wait. Over periosteum, feel resistance, click. Bolus, retrograde. I go further laterally. This is the area of the zygomatic retaining ligament. Click. Bolus, retrograde. Okay. Now I get to the molding part. It's rock and roll. So I push and I roll. I push and I roll. I push and I roll. So, straight. Look in the camera. Do you see a difference?
Want to sit up?
So you see lifting effect, improvement of light reflection, especially compared to the other side. But you also see that we actually have created one problem. Do you know what I'm seeing? Can you see what I see? What have I done wrong? What was it you said? Some shadow. Some shadow over here. Yeah. So we need a second entry point. And also, I will get to that. I will get to that. Go, lean back, please. Yeah? Lean. All right. Okay, needle, thank you. Okay. So the second entry point is at the lower border of the zygoma, approximately at the lateral orbital rim. From here, again, I can go subsmas, click, in between the two ligaments, And she's getting a little bit tired of me now. Click through, bolus, retrograde. Click through, bolus, retrograde. Click through, bolus, retrograde. Alright, so these were the lifting, these were these lifting injections. Now, you are completely right, there's still a bit of hollowing over here, and that I can treat with giving subcutaneous retrograde linear threads over here, over here, over here, over here. And I can also do that from here, because it will give a little bit of volume, and it will give a little bit of, let's say, transitional light reflection, because I actually like to have a little bit of shadow over here in the right vector, so in the right direction. Okay. All right. Is that better? Is that better? Yeah? Great. Now, the last thing I will do today, and that is something that we have to be able to treat if we do a cheek augmentation, because if you look closely, you see that we actually have created a problem by giving her a nice cheek. The problem is a deepened palpebromalar groove, because the more that you inject in the cheek, the deeper this may become. And this is also one of these areas that if you become older, you have bone resorption. Bone resorption, especially in the infralateral side of the orbit. So this becomes deeper. So the deeper this gets, the more evidence you see of bone resorption. So it's proof of being old. If you inject a little bit of Belotero Intense over here, and you know what? I think she's really tired of me, so I'll numb her a little bit. I'll give her a little bit of anesthesia. 1, 2, 3. For the entry point, and then there's a nerve here, the zygomaticofacial nerve. Okay. 0.25, yeah, that should be fine. Cannula, please. Needle. Okay, palpebromalar groove. So I will go from the lateral part to the medial part, through the muscle. So I will lift up the tissue in front of the cannula, advance the cannula until I get to periosteum. Okay. Check tip location. It's over here. Start to inject. About 0.1. And then again, rock and roll. And I think I created a little bruise with the anesthesia. So unfortunately, you won't be able to see the final result right now. She did very well. I saw that she was suffering a little bit. Yeah. And in the last injection, of course, we hit the blood vessel. That's what happens. Mm-hmm. Okay. So just one last thing I would like to point your attention to. If you inject the palpebromalar groove, and just ignore the bruise that is coming here, okay? But look at the position of the lateral canthus and compare it to the position of this lateral canthus. You see that there is a improvement in the tilt, the canted has been pushed up. Do you see the difference? It's really swelling now, so maybe you can put some pressure. I might have hit her zygomaticofacial artery, because there's a little foramen down there with a nerve and an artery. I was trying to hit the nerve with the anesthesia, but probably I have also hit the artery. So for anesthesia, it's good, but for the bruise, maybe not. All right, ladies and gentlemen, thank you so much for staying so long. And I don't know about you, but I would like to have a nice glass of wine right now. Thank you very much.